Hi everyone, and welcome to our very first GCR Connect end of year showcase. I'm really excited to have you all here today to listen to some amazing presentations. So before we begin, GCR Connect acknowledges the traditional custodians of the various lands that we are all meeting on today. So for me, I'm on the lands of the Gadigal people of the Eora Nation. We pay our respects to elders past and present and extend that respect to all First Nations people present today. Would also like to acknowledge that sovereignty was never ceded and that this always was and always will be Aboriginal land. So as I said, we have some amazing speakers today. We will have our keynote speaker first, who is Associate Professor Stephanie Best, and I will introduce her very shortly. After Steph's presentation, if you have questions, please do pop them in the chat, and I will aim to get as many questions answered as we can. After this, we will have our, our GCR Connect members' presentations. These will be about 5 minutes each, with an opportunity for questions after each presentation. Again, if you could please pop those in the chat. And again, I'll try and get as many answered as possible. So now it is my absolute great pleasure to introduce our keynote speaker for this afternoon, Associate Professor Stephanie Best. So Steph is an implementation science researcher investigating the translation of complex health interventions into routine clinical practice. Steph is the Senior Implementation Research Lead at the Peter MacCallum Cancer Centre, Victorian Comprehensive Cancer Centre and Australian Genomics. Personally, Steph and I have worked together on a number of really big national projects, including the Acute Care Project and Mackenzie's Mission. And I have always found her advice to be incredibly invaluable, and her enthusiasm for implementation science research absolutely infectious. So please welcome Steph with her presentation entitled Where to Start with Implementation Research.
Kirsten, thank you very much for that very warm welcome. It's an absolute pleasure to be talking with this group. As you say, Kirsten, you and I have worked together on sort of many projects, and I've worked with many GCs over the last sort of 5 years or so. So it's an absolute pleasure to be here talking with you today. So I've titled my presentation "Where to Start with Implementation Science." There's a lot of people who kind of seem to be implementation science curious, or they kind of say to me, "Oh, well, I do implementation research anyway." So maybe they don't want to hear about this. So I just thought it might be interesting to just kind of really go, I am interested, but where do I go to from here? So let me just do the difficult bit of sharing my slides, which is, it's always good to have these challenges straight off. And I am hoping that you can see them because it's filled my screen and I can no longer see anything else. So let me keep an eye on the time. So I have put my contact details down in the corner here. So I'm at Peter Mac. Now I've moved from MCRI, still working with Australian Genomics, as you can see here. I am on Twitter, but I'm kind of, well, you can't see them.
Yeah.
I'm merrily chatting away to myself. How about if I do that?
Excellent. There they are. Yep.
So I do apologize. So I'm going to be slightly over here because I've put those over here and I know that you're all there. So bear with me if you see sort of more of my grey than you would do maybe if I was facing straight forward. Anyway, I've waffled on enough. Let's crack on to sort of my first slides here. So the question that we might want to ask ourselves is sort of why do we want to bother with implementation science? You're all really busy GCs. You've all got enough to do. You've already got enough to do with the research that you've got on your plates. It's sort of why do we want to be thinking about another discipline, another sort of area of research? One, obviously, because I think it's fascinating. But two, probably more importantly, is this sort of cartoon, this sort of slide here shows, the latest research shows that we really should do something with all of this research. And this is really true. We have an awful lot of clinical evidence that we're generating, which is great and very exciting. But that doesn't necessarily mean that it changes practice. It doesn't necessarily mean that the care that our patients get at the end of the day changes. It doesn't mean the experience that our patients are getting is any better unless we get that evidence into frontline clinical practice. then it's just an interesting piece of work. So we really want to see that research come through into clinical practice, to be making a difference beyond just sort of maybe the department that we might be doing the work in, and maybe beyond even the hospital or even the state. We want to see the research that we're doing that can demonstrate some sort of change in clinical outcomes or patient experience actually is disseminated as wide as we can manage. So there seems to be a party going on in the background here, so I do apologise if you can hear lots of cheers. So my next slide is really here about why is it difficult to be thinking about implementation in healthcare. And there's kind of two main reasons really that we might want to think about. One is to do with the system itself. Healthcare itself is a complex adaptive system. And when I say a complex adaptive system, what I'm talking about is the fact that we are autonomous practitioners within that system, and we form, not only do we have our hierarchical structures, but we then form informal collaborative networks. So whereas you might see on a piece of paper that A will talk to B, but actually no, we talk to C and we talk to D. And so the information and decision-making it's really difficult to track sometimes. From this, we get emergent patterns of behavior that we wouldn't necessarily expect. So all of those workarounds that we know and love are not necessarily things that have been planned, but they happen all the same. And the system itself changes. The system itself adapts to cope with all of the changes that we are putting into place. So we've got this complex adaptive system, and then we're putting individuals on top of it. So we can think about consumers and we can think about patients. Consumers and patients, we can think about clinicians. But when we think about changing behavior, we might want to think about changing behavior in either of those two groups. We're often relying on what we call intuition. So our gut feeling, this is what we think is the best thing to be doing. We don't always get an understanding of what the mechanisms are that are around those, what could be the barriers to change. And because of that, we don't necessarily then build the methods that then help us provide those sort of necessary components to provide effective change when we're thinking about behavior change. So hopefully I've convinced you of some of the reasons as to why we need to be thinking about using implementation science. So if we're thinking about changing practice, there can be two kinds of ways that we might want to be thinking about this. One can be top-down. So we might be thinking about policy directives, we might be thinking maybe of financial incentives, or all sorts of things like that, that sort of are really sort of messages that come down that kind of say, if you behave like this, this is the way you should be behaving. Or if you behave like this, then this is going to be what happens. Or we can think about bottom-up approaches. So things that happen at the grassroots and then can then infiltrate up. And we often find that in a complex adaptive system, it's those bottom-up type approaches that can have more leverage. And if there's something that you're interested in, there's a very interesting website, the Epoch Cochrane website, that talks about what evidence there is around some of the interventions that we might think about putting into practice. Point you to that website. It's an interesting read anyway. So I'm going to focus very much on the bottom-up approach, which probably is of no surprise to you. And probably the first thing to say really is when I'm talking about implementing some sort of change, what I'm talking about here is about implementing a piece of evidence-based practice. So I'm not talking about practice that hasn't got any evidence behind it. And when we want to do this, the first step that we need to be thinking about is really about understanding that context. And so when we want to understand the context, there are multiple people that we need to talk to. We need to gain a real understanding of the situation and what it is that we want to be putting into place. And there's a couple of steps that we might want to think about, or I would encourage people to think about when we're at this very, very early stage of going, sort of really understanding the context. So the first step is really about understanding the problem. We very, very commonly get very giddy and excited, and I speak as a clinician of several decades experience of being very solution focused. We want the best for our patients. We can be quite action orientated. We want to put things into practice and we want to see things change. But I'm really, really encouraging you to take that step back and go, okay, that might be a fantastic solution, but actually what is the problem that we want to be solving? Is there any evidence that this is actually a problem? Is it something that we may have? There may be some quantitative evidence around it. There may be some qualitative work around it. Have we spoken to consumers to really find out that the thing that we plan to spend a lot of time investigating is actually a problem that consumers agree with you is a problem? Once we've really kind of understood that and we've kind of got to the nitty-gritty of really knowing what our problem is we can then start thinking about what is the solution. Now, when we're thinking about the solution, we want to be looking at, well, what kind of evidence is there that says that this solution, this evidence is going to work in this kind of context? And again, we want to be thinking about our wider stakeholders here, particularly our consumers. Is this a solution that's going to be appealing for them? Or do we want to be looking at a wider group than that? Do we want the perspectives of clinicians and consumers? So, for example, I'm doing some work at the moment about developing a bi-directional platform between clinicians and consumers. So clearly, there's no point in me getting the perspectives of one group and not the other group, because we might end up creating something that doesn't meet anybody's needs. The third step in this sort of early stage is really thinking about how can you how can you fund investigating this idea? So we might want to think about there's often sort of little pots of money that you might be able to look to see if you can get yourself awarded and grants that you can go for. They don't have to be huge MRFF grants. Often units will have smaller grants that might just give you some of that seed funding that might just help start you on your way to investigating this problem. So if we don't spend our time in these sort of early steps of sort of going through this problem, this sort of process, what we can end up with a solution which is called the Isley solution. And this stands for, it seemed like a good idea at the time. And so this image that I've got here is an invention that somebody came up with so that you can clip 4 fingernails all at the same time. It's a solution. I don't know whether it's got a problem that the solution is going to answer, but it's kind of one of those questions, is this something that we really need to see? So we've spent our time in this first phase of really understanding the context, really getting immersed in this, really spending our time in this area. We don't necessarily want to be spending our time in this place because sometimes it feels like we're not actually doing, but we're really, really understanding. The next step when we're thinking about implementing evidence-based practice is thinking about what are the kind of strategies that we might want to be thinking about when we're putting an intervention into practice. Now, it might be, or hopefully, you've used some sort of theoretical approach in that very, very early stage, and we can often use those theoretical approaches to help identify some theory-informed strategies. Now, it's not to say that we can't use some of those strategies that we kind of in our gut think might be the right thing to do, but we can use them alongside each other, and so they can inform what it is that we're going to be doing. The next step that we want to be doing is obviously putting those strategies into place. And finally, and this is another one of those steps that is not as well dealt with, is we need to assess whatever it is that we're doing, and we need to revise whatever we're doing. The chances of us getting something right the first time, even going through this process, are very, very slim. And even if it's kind of quite good, then oftentimes we're going to want to revise it and make it even better than it is. So although I've demonstrated this in a sort of linear kind of way, clearly it's got quite a sort of cyclical nature, and there's sort of feedback loops kind of going all over the place here. And it's definitely these sections in the middle. We're pretty good at these sections in the middle. We'll go get and we'll do, and that's fantastic. And I love that passion and enthusiasm. But it's really this first and this last step that we need to stop and spend some time and think about. Now, I often like sharing this slide here because this is really thinking about what are the outcomes that we might want to be thinking about. And this comes from a paper from somebody called Enola Proctor, who's an implementation scientist over in the US. So we're quite familiar with this concept of health outcomes because of the work that we work in. So the kinds of things here, it's sort of somebody's health status, or it might be around their function, that kind of thing. Oh, And then we're sort of more familiar these days with service outcomes. So we're talking about efficiency, we're talking about safety, we're talking about timeliness, all of those kinds of things. But there's also a third set of outcomes that we might want to be thinking about, and these are more based on the outcome. Blimey, what's happening to my slides here? These are more based on the implementation itself. And so you can see here the implementation outcomes that we've got vary from things like acceptability and go all the way through reach and fidelity and all the way down to sustainability. Now, I'm not saying for every project that you do that you need to include every single one of these implementation outcomes. In fact, it would be if you came to me and said, Steph, I want to do this, I would sort of say, right, let's have a cup of coffee and we'll talk about this, because really what you want to be doing is selecting what are going to be the appropriate implementation outcomes for you to be looking at with your implementation project. Equally, you don't have to be looking at all of these service outcomes or all of these health outcomes, but you might want to be selecting something that's a health outcome, something that's a service outcome, and an implementation outcome. And if you don't, it just gives you a nice framework for you to be thinking through why you do or don't want to be including something. Aha, the next slide. Frameworks galore exist in implementation science, which is both a blessing and a curse. So the blessing side of it is there is often a framework that will be helpful for whatever it is that you want to be looking at. On the flip side of that, there's just so many of them. So where do you start? And you can see here, this is, if we look at this sort of line in the middle here, that gives you the sort of three kind of groupings that we've got around implementation science frameworks. So they might be for describing and or guiding the process of translating research into practice. It might be about understanding and or explaining what influences implementation outcomes, or it might be about evaluating the implementation. Either way, it's really, really important that we think about using theories, models, and frameworks in the studies that we're doing. It improves the efficiency of what we're doing. It means that we can build on what has already gone before, standing on the shoulders of giants. If we don't take the time to be, or if we don't use theories, models, and frameworks, being able to transfer that information of stuff that's already gone before, or being able to put it forward, is much, much more challenging. And it can really help us from not reinventing the wheel. We can think that we've got a great idea that we want to do, but we need to see what others have done before us. Using some sort of framework can also help us identify some of the factors that have influenced the implementation, and either whether it's sort of the implementation, the intervention itself, or whether it's the implementation strategy, it can help us understand why something has succeeded, or if it hasn't succeeded, why has it not succeeded? And finally, it brings us on much more of a scientific footing. So it helps us move away from just having, we've talked about that sort of gut feeling, that sort of implicit understanding of what drives change. And by getting much more of an understanding of this area, it means that we're going to be able to have a better chance of replicating what it is that we're doing and in growing the knowledge that we've got in this area. So at this point, I am very, very commonly people say to me, oh, just tell me, Steph, what framework should I use? I just want to do some research. Sadly, one size does not fit all. I can tell you all about all sorts of different frameworks, and I can teach you about one particular framework, but that doesn't mean that you can then use that one framework and use it in every study that you want to do. You'll find that the framework that you want to use is going to vary depending on the question that you're asking, the context that you're in, and also down to the individual expertise and the skills of the researcher that you've got in front of you. And so you can see from this sort of cartoon here, sort of, if we go for this one size fits all, the chances of having a framework that's actually going to be fit for purpose are very, very unlikely. Whereas here we can see is actually if we spend that time and really work out what it is we want to use, that we've got a much better chance of having a nice, snug, appropriate fit. So I thought it might be helpful if we just perhaps went through this row of this graph here and looked at maybe some examples from each of these different sort of categories. So the first one that I said is around describing and or guiding the process of translating research into practice. So this group of frameworks is really good for giving you a helpful overview of some of the steps that you might want to be considering. It can help you articulate at which point you are in the research process. And so the example that I've given here is the knowledge to action framework. Been around for a long time, the K2A framework. And you can see we identify the problem, we go about generating knowledge and how we synthesize that, and we tailor it to our particular community that we're in. And we then start going around, we start looking at these blocks that we've got that go around the edge. So we might want to adapt the knowledge to our particular local situation. We need to identify the barriers that we've got in a particular challenge or area that we're looking at, tailor the interventions that we're thinking of. We can't just put something into practice and then not monitor it. So we need to keep an eye on what's happening, evaluate those outcomes, health service implementation, whatever it is that you're selecting. And then we need to be thinking about sustainability. And you can see these are all two-way arrows. So we might want to think about, oh, actually, we haven't got enough of this. So we might want to back up to sort of further back in the loop. So this can be quite a nice framework to help with that sort of, this is where I'm at. You might want to use a different framework within some of these different steps, but it's quite a nice one for helping with this sort of articulation of the whole process. The second one that I'm sharing with you here is around understanding and or explaining what influences implementation outcomes. And again, there's a whole load of frameworks that we can talk about in here, but this is quite a nice one to pick up, I think. This is the COM-B framework. A lot of you may well have heard of this one. So this talks about the idea of capability, opportunity, and motivation. And what Mickey and colleagues argue is that it's these three factors that influence our behavior. So if we can understand our capability, so we can do it, or our opportunities, it's actually possible to do something, or our motivation, it's something that we actually want to do. If we can understand these three areas, then we can address our implementation strategies specifically. We can target them specifically to say, for example, capability. I don't know what it is that I need to do. Fine, we can tackle that with education. Or actually, I don't really want to do it. Well, we need to get in underneath why does somebody not want to do it and how do we support them through that? No point in educating this group here because that's not going to have any impact. So if we can understand what it is that's influencing our implementation, then we've got much more of a chance of influencing behavior. And then the third one in that row is around evaluating implementation. And so here I'm sharing another pretty well-known framework called the RE-AIM framework. And so you can see here we've got the RE-AIM stands for reach, effectiveness, adoption, implementation, and maintenance. And so this framework can be quite a nice one to help us articulate how we want to go about evaluating our implementation activity that we've been doing. So, for example, reach, did we get to the people that we wanted to get to? Effectiveness, how do we know whether what it is that we've done has had any impact or not? Adoption, so how do I develop organizational support to deliver my intervention? So what is it that we need to be putting in place from that perspective? Implementation itself, how do I make sure that the intervention is delivered appropriately? And then finally here, how do I maintain it? So all of these frameworks that I've talked about so far, these three, they've all got their strengths and weaknesses, but most importantly, their time in the sun varies. There's one final group I just wanted to talk about. It may be that you've got a specific lens that you want to use on your implementation process. And so, for example, equity is an area that we have a lot of interest in implementation at the moment. Are we closing an equity gap or are we growing an equity gap when we're thinking about putting some sort of intervention in place? And so you can see as we go, this is Levesque's framework on access. And you can see the accessibility, and here we can think about, are we talking about providers, organizations, institutions, systems? And we can also talk about the ability of, and here again, we can look at this at multiple levels. So populations, communities, households, and individuals. So if we want to talk about equity, then we might want to be looking at it from multiple different perspectives, provider and consumer. And then we might also want to be thinking about it along that sort of consumer pathway, sort of identifying those health needs, and then sort of coming all the way along through sort of healthcare, that reach of healthcare, all the way along to thinking about, well, what are the healthcare consequences and how do we want to divide that up between economic, individual satisfaction and health outcomes themselves. So there's a whole range of things we might want to think about. But most importantly on this slide here is really thinking about, is there a particular lens that you want to be doing? I'm not saying that you've necessarily got to be looking at equity here, but this is just an example of something that you might want to think about. I can't do a talk about implementation science without talking about the importance of collaboration. And this image that I've got here is of the Welsh football team, who very, very sadly have just been knocked out of the World Cup. And the reason I've selected this image here is not only do we have a whole load of different people from the actual team itself, but we've got the star player, Gareth Bale, here, and he's commiserating with some of those backroom staff that are part of that whole collaboration that have managed to get Wales to the World Cup, which is the first time in years and years and years this has happened. So when we think about this in our context, then we need to be bringing together that content expertise. And that's where I've been very fortunate and worked with a lot of GCs over the last a few years. But we need to be bringing that together with our implementation expertise and bringing those across. Good implementation research is not something that you can do in a little corner and hide it on your own. It's a very, very shared experience. It's a very, we need to be bringing everybody together to be talking about it and thinking about how it is that we want to be implementing. All of this builds on the usual prerequisites when we think about implementation science and implementation research. Is we need that basis of good data science. We need to be thinking about collaboration. Clinical engagement is essential, and really recognizing that we want to put something in place, but it isn't going to be quick and it's not going to be cheap. So how are we going to be addressing maybe our expectations, other people's expectations as to how we're going to be managing this? Final slide, just to say that implementation science, I would argue, provides a great theoretical platform and useful platform to help you structure your implementation using some sort of theoretical framework. It can support that move from just using intuitive gut feeling ideas of what might work into using theoretically informed strategies. It can help us understand in these complex interventions, and everything we do in healthcare is complex. It can help us understand what works for who and when it might work. And all of these things, if we sort of add all these things up together, these are the factors that can help us when we want to think about generalizing something and thinking about scaling up interventions. Thank you so much for the opportunity to talk this afternoon. It's been a pleasure.
Thank you so much, Steph, for that wonderful presentation, and certainly given us a lot to think about, you know, when designing our own research projects. I guess if people have questions, if they wouldn't mind popping them in the chat, we've got a few minutes for questions. So if you can put them in the chat, but I might kick things off because I know people are often a bit shy to ask their own questions.
Aren't we all, Kirsten?
Aren't we all? Aren't we all? So I was thinking more, I guess, towards the end of your talk when you were talking about the collaboration aspect of implementation science. So, I mean, this might be a bit of you'll probably have a biased response to this question, but do you think when we're developing our own research that we should be, I guess, either factoring in implementation scientists to our grant applications, or should we be, I guess, seeking advice? Like, how do we practically get implementation science involved in our genetic counselling research?
Yeah, no, I think that's a really, really good question, Kirsten. And I think all of it comes back to what is the question that we want to ask. And so if the nexus of the research that you want to be doing is, say, very much embedded in GC theory and reasoning kind of thing, it might be that you don't need to be thinking about sort of any implementation. It might not be relevant at all. But if you're thinking about how you might want to be putting something into practice, then yeah, absolutely, I would say that you need to be bringing some implementation. And I totally have insight into my bias. But I just think even, and a lot of people say to me, but we don't have somebody like you in our department, and, you know, sort of what do we do about that? I would encourage people to be seeking out somebody who's working in the field of implementation research. There are lots of implementation practitioners these days who are sort of very, very hands-on, who can sometimes sort of provide advice. And even, it's not even, you know, it might even just be a cup of coffee that you want to have with somebody, and really to be thinking out loud and working through that structure of what it is that you want to be doing. So, for example, recently I was working on a protocol, an ethics protocol with some colleagues of mine. And a lot of what I was doing was really just trying to pull out, is what we're asking here something that we can answer through using implementation, or is it, or do we need to sort of restructure what it is that we're doing? And so it might just be about having those initial conversations. If you're looking at bigger projects and we're thinking about implementation, then yeah, it is something that we do need to be thinking about. How do we fund and how do we cost in that time? If we don't cost in some time for somebody to work with implementation, it's the same with the GCs. If we want the GCs to be working on a project, we need to be funding that time for the GCs so that they can actually be contributing to whatever it is that we want to be doing.
Great answer, thank you. Any other questions from people? Still too shy? Another 5 minutes worth of questions if people wanted to ask Steph anything.
I think I've excited people far too much with all of my frameworks. I tried to be as delicate as I could with frameworks, but I think there's quite a few people who've probably heard me talk before, so I kind of wanted to share a few more of them. So
no, great to have some practical things that we can, you know, think about, as I said, when we're thinking about our own research, definitely. I guess I have another question if there's none in the chat. Once we sort of have that implementation science research and, you know, we've done our research, we've done the implementation science stuff as well, how do we then, I guess, ensure that, you know, that the policymakers and people like that actually listen or receive our message? Because I think, you know, obviously, the projects that we've worked on together, Steph, that we have had trouble getting to that next stage. And I wondered if you had any words of wisdom for us.
I think two things that might be combined into one. So let's see how my words go and whether it becomes 1 or 2 points. Is really thinking about who we want to get engaged with the research at one point, or what point. So obviously, if we've got something that we're still generating the evidence and we need to sort of build that, then it might be a little early for us to be getting sort of policymakers and people like that in. But actually, if we're getting to that stage where, you know, it's a no-brainer, we absolutely should be doing this. We've got the health economic data that goes with it. We know how it is that we should be doing this. Then I think it would be quite handy if we have a really wide group of stakeholders and bring into that people like policymakers and healthcare decision makers into that sort of almost learning health community. So we can think about the people who might be working on the project, but actually who are that next stage out that we should be getting them involved. So almost so they've got some skin in the game early doors. So it's kind of like we're collaborating on the work that we're doing, and that's all essential. But then, and we're, to start off with the project, we need to all be quite relatively sort of internal facing as we kind of kick something off. But then it's then thinking about at what stage do we become much more external facing and start to see who it is that we can start bringing in along that journey.
Great advice. Oh, we've got a question. Okay, question from Gayatri. So thank you, Steph, for a wonderful presentation. I wondered when we draw the line with when it's worthwhile to perform implementation research or when we forge ahead with an implementation plan for a service. I often struggle with the question of a common sense approach versus investing in the implementation research question, which is often very valuable. Sorry, it's such a broad question. I'd love examples of each scenario in your own experience.
Oh, I think that's a great question. And it is hard, isn't it? Sort of having been in clinical practice, you know, sort of where do I want to actually be thinking about research and when do I want to sort of just crack on and do something? And I think the difference for me is when we know we've got our clinical evidence and we know we have our implementation evidence that we know the best way to be putting this into practice is X, Y, and Z. For example, we know that knowledge is a barrier, and therefore we need to be educating people, and this is going to be the way that we're going to put it into practice. Or we know that professional identity is one of the biggest challenges. And so actually we need to be engaging with the professional bodies and some of the key thought leaders in a particular profession to be helping get a clinical intervention into practice. But if we're at that stage before that, where we haven't generated that, that research, that implementation research, we might have a clinical intervention, but we might not know what the best way is to put something into practice. That's the time when we need to be thinking about how is it that we're going to go ahead and put this into practice. And so Mackenzie's Mission is a great example of that, isn't it? So Kirsten and I worked on a project called Mackenzie's Mission, where it was a national project looking at the implementation of reproductive genetic carrier screening and offering it free to couples. And so we were interested in how was it that, for example, perhaps we just look at the education, how was it that our healthcare practitioners wanted to receive their education? And so part of the study we did looked at giving people education directly with the GCs, a video of the GC providing the education, just written information on a website, or videos and some written information on the website. So we didn't have that information before we did this study. So that's an example of where we would start thinking about doing that implementation research. Most of them liked the face-to-face, but equally, a lot of them also liked the more video online. Less of them liked just the ready bits, which I think I probably would like. So those are kind of two examples of when we might want to think about when it is that we want to be thinking about how it is that we're going to be, whether we need to be doing implementation research. The other time that you might want to think about doing implementation research is when it kind of feels like a no-brainer. Why is everybody not doing this? We all know this is a great thing for our patients. You know, it's kind of like, and so that can be a time when you might want to be thinking about doing some implementation research to work out why is something not going the way that you expect it to go. So totally my bias. And of course, I'm going to give you all sorts of examples as when you should be doing implementation research. But I do agree with you. There are times when we know what it is that we need to be doing, and we know how it is that we want to be implementing. We know what those key barriers are. Lovely question.
Thank you, Steph. Well answered as well. If there are no more questions, we might wrap it up there for you, Steph. Thank you once again for joining us on our first GCR Connect Showcase. We're honoured to have you.
Absolute pleasure. I'm honoured to be your first keynote. Thank you.
Wonderful. All right. Thanks, Steph. So now we are going to jump into our GCR Connect member showcase. So I'll just very quickly introduce everyone all in one go, but please do, after each presentation, we will have 1 or 2 minutes for questions for each speaker. So please do think of questions and pop them in the chat, and I will aim to get them answered. So running through, we first have Ms. Laura Yeats from the Centre for Population Genomics. Second up, we have Dr. Gillian Blue from the Heart Centre for Children and University of Sydney. Thirdly, Mr. Lucas Mitchell from the Garvan Institute of Medical Research. And our fourth speaker, also from the Garvan Institute of Medical Research, is Ms. Mary Ann Young. And rounding up the Garvan Institute of Medical Research presenters, we'll have a presentation from Dr. Amanda Willis. And last but certainly not least, Ms. Elle Martin from the Murdoch Children's Research Institute to wrap up the day. So with that, I will hand over to Laura. Thank you very much.
Thanks very much, Kirsten. And yeah, thanks to the GCR committee for having me speak today. So today I'm going to be talking about one of my PhD projects titled COPE SCD, an online community supporting families after sudden cardiac death. So sudden cardiac death in the young is a devastating complication of many genetic heart diseases and tragically can be the first presentation of disease. When we look at causes of sudden cardiac death, up to 40% have no cause of death identified at post-mortem. And so in these situations, we suspect inherited or genetic arrhythmia. So where a genetic heart disease is either identified at post-mortem or is suspected, then we recommend clinical screening, because most of these conditions are autosomal dominant. So most family members have a 1 in 2 chance of having the same condition. Next slide, please. But what about the psychological impact of sudden death on the surviving family? Some research from our team have shown that mothers particularly have higher levels of anxiety and depression than other family members. Up to 1 in 2 family members have symptoms of prolonged grief and/or post-traumatic stress, and that those who witness the event or discover the decedent are 4 to 5 times more likely to have prolonged grief or post-traumatic stress. So a few years after this study, we wanted to understand this more and conducted a needs analysis of parents who had lost a child to sudden cardiac death. And to cut a long story short, this study showed that medical information and support and psychological information and support were needs that were endorsed by our participants, ranked of high importance, and yet remain unmet in a proportion of participants. So with that in mind, we have developed, next slide please, Will, COPE SCD, an online community supporting families after sudden cardiac death. So we use stakeholder co-design with healthcare professionals and family members who'd lost someone to sudden cardiac death to design a support intervention. From those stakeholder co-design focus groups, we were able to take our key themes and build them into the main parts of our intervention. The first part of the intervention is a website. The website provides information in written and video format, thank you, and links families to the second part of our intervention, the online sessions. The online sessions are a series of 4 sessions, each with a different topic, and they allow an opportunity for peer support and build on the information provided in the website link people back to resources. Next along, please. So we're now in the process of, just hold up there for me, Will. We're just in the process of piloting our study, and the aim of our pilot is to assess the feasibility, usability and acceptability of the website and online sessions. We'll be recruiting from the Genetic Heart Disease Clinic at Royal Prince Alfred Hospital using a purposive sampling approach. Next along, please, Will. And also social media. And if the participants consent to participate, they'll complete a demographic questionnaire and a baseline questionnaire. For aim 1 for the website, we'll be doing a think aloud analysis. Next along, please, Will. Using a think aloud analysis is a qualitative research technique where we show the participants the website and ask them to think aloud. In aim 2, which is assessing our online sessions, just go all the way through now, Will, thank you. The participants will participate in each of the 4 sessions with a post-session questionnaire, and then they'll complete the baseline questionnaire again. Next slide, please, Will. Sorry, I've got too many animations. And then they'll do a qualitative interview. One more for me, Will. And then we'll repeat this process as necessary as we refine our sessions. So in summary, next slide, please. Sudden cardiac death is a devastating complication of many genetic heart diseases, and we have used co-design with stakeholders to allow us to develop an intervention that directly addresses the needs of sudden cardiac death families and fills a large gap in existing healthcare. The pilot is underway, and I look forward to sharing more results with you once it's done. Thank you very much.
Thanks so much, Laura. Does anyone have any questions that they would like to ask Laura? Wonderful. One from Ryan, straight up. So Laura, you can probably read that, but I'll read it out anyway. So Ryan's wondering if you have any preliminary findings on acceptability of an online intervention for peer and psychological support in the space of SCD.
Yeah, thanks, Ryan. Great question. So I use an acceptability framework, SECHORN. I can put a link in the chat in a minute. And that uses 7 different ways, 7 different, what do they call it? I guess domains of things of how to measure acceptability. So far, I've run 1 round of the online sessions, and I've just done one of the qualitative interviews today. Overall, people are saying it's acceptable. There's different things that we can improve that we'll look to improve the next time round. But yeah, like it looks at things like burden, so the amount of time, did it align with their values and all those sorts of things. So far, it's looking good, but the data is literally coming in, as I said, just today. So I'll be mapping that back as I analyze to the acceptability framework. So I highly recommend them. They help you, as I designed and used frameworks, it just helped me think about my questions to ask the participants in a structured way.
Thanks, Laura. And we've got a question from Ron. Are there any risks of peer support for such an emotional experience? Is there someone there as a moderator?
Yes, Ron, there is. So these were run by myself as a genetic counsellor, but also we had our clinical psychologist attached to, who we are lucky enough to have one who sits in our department of cardiology. And after running one lot of sessions, it was clear to us that as we implement this hopefully in other services around the country, having the clinical psych as a part of the program is going to be extremely important. Yeah, and so then if, of course, we cause distress, then we have a distress protocol if people pull out to check in with them, and we can refer them to further services as well.
Wonderful. All right, thanks, Laura. We might leave it there in the interest of time. And I'll hand over to Gillian.
Thank you very much. Can everyone hear me and see me? Oh.
Yeah, all good.
Oh, good, great. Thank you very much for the opportunity to present here today. As Kirsten mentioned, I'm Gillian Blue. I'm a research genetic counsellor and have been for many, many years, 15 years and counting. So I've been involved in a number of research studies throughout the years and still am very much involved. So I thought I'd talk about one of the newest studies that we've recently started, looking at genetic health in adolescent congenital heart disease. And this is really a project that I've co-designed with my clinical research assistant, Bridget O'Malley, and she's really driving this research project. Next slide, please, Will. So congenital heart disease, for some of you that don't know, is a structural defect of the heart. There can be many different types, simpler lesions such as holes in the hearts, which many of you might have heard of, as well as more complex and severe lesions where half the heart is underdeveloped or not developed at all. Congenital heart diseases are the most common birth defect that we see and affect about 1% of babies that are born. So they really result in a significant and large patient population. So with improvements in cardiac surgery and care, over 90% of these children are now surviving to adulthood, which is fantastic. And you can see in the graph at the bottom, the significant or exponential increase in the adult CHD population over the last couple of decades, such that the adult CHD population actually outnumbers the pediatric population. And the adult CHD population really do have their own unique medical, but also psychological health concerns. And many of them do consider family, and I've included a picture of one of our research families in the corner of the slide, where dad had a significant heart defect repaired as a boy, and he has a boy himself now who has a more severe and complex form of congenital heart disease. He actually has probably the most complex form that you can get, where hypoplastic left heart, where half his heart has not really developed. And so with recurrence risks in congenital heart disease ranging between 2 and 20% for non-syndromic forms, with I guess really want to highlight those with isolated non-syndromic forms falling at the bottom end of that spectrum. But still, with this population or group being, or large, this patient population being quite significant, next button, Will, there really is a need for a genetics education program to inform family planning for this expanding patient population. Next slide, please. So with this in mind, we've been thinking about developing a genetics education program for transitioning adolescents. So when they're moving from pediatric care through to adult care. And as part of this process, and I think this links in very nicely with your talk, Steph, the research aspect of this really will be the implementation of this genetics education program and monitoring it and evaluating its progress over time. But before we could really even start developing a program, it was really important for us to get a good understanding of our patient population. With Australia being a very diverse population, it's really important to understand their adolescents' unique needs and preferences, especially when it comes to genetics related information. So what we've decided to do is to survey adolescents attending the Heart Centre for Children. We will be surveying them as well as their attending parent. So we'll have an adolescent parent dyad. We will also be surveying clinicians involved in the care of those with congenital heart disease via the Cardiac Society. And this is really to get an understanding of current practice surrounding this information and also their preferences and you know, how they would like to see this information disseminated to their patients. So we've developed 3 separate surveys. They're individualized for each of those participant groups. However, there are some common survey items. Obviously, we'll be getting demographic information as well as general and heart health. We also want to get an idea of their current understanding of congenital heart disease and inheritance. And then most importantly, obviously, get some information regarding to preferences in the content, delivery and timing of the genetics education program. Now, as I mentioned, we've just started this survey or this study. We actually started recruiting a week ago. We've had an incredibly positive response, and we're really hoping that this information will inform and really help to inform and develop the program down the track. We're going to be recruiting for about 6 months as we really want to maximise our participant numbers and representation of patient diversity. And with that, I'll say thank you and any questions.
Thanks, Gillian. That was wonderful. Does anyone have any questions that they would like to ask? I've got the chat open so that I'm ready. Nothing yet. So I'm going to take this opportunity to ask my own question. I was sort of interested, Gillian, because I know that you've worked in research for a long time. And I guess I was just interested in hearing more about what attracted you to working as a genetic counsellor, but working in research. I think it would be interesting for the network and people listening to understand where you've come from.
Thank you very much, Kirsten. Yes, I think it was the challenge. I love a challenge, and I think research really informs the questions and how we address our patients. So I think having the balance or a patient as well as a patient-facing side to a role as well as a research side to a role addresses both those aspects that I'm incredibly passionate about. So, and being able to come full circle, I think, has been an incredible reward, seeing I've been in this long enough. So with my PhD, establishing a couple of studies and working out some new techniques and ways of assessing genetic testing for patients with congenital heart disease, and then coming full circle now where we actually have a clinic where we can offer this testing clinically, and it really being informed by the research that we've done. So it's incredibly rewarding, and I would encourage as many GCs as possible to start thinking about research and possible options and ways that you can incorporate this in your current role as a clinician. As I said, incredibly rewarding, and it really is a two-way street So going, feeding back to your patients with the information, but then also using that patient feedback to inform your research questions. So I think it goes hand in hand and really makes for a very well-rounded and rewarding career.
Thanks, Gillian. Any other questions from any of the audience members? Speak now. All right, well, we might leave it there. Thank you again for agreeing to present today. It was wonderful to hear from you. Thanks. All right, next up we have Lucas.
Hi, everyone. Thank you for having me here to talk about one of the projects I've been working on. Just a little quick introduction. My name's Lucas, and I'm a research genetic counsellor based here at the Garvan Institute of Medical Research. But I just want to start off perhaps with a question just to kind of get everyone in the headspace or the mindset. And I'd like everyone for a minute just to imagine you're at your desk and you discover information that could have health implications for your participant, but it's unrelated to your research project. Would you know what to do with these results? What steps would you take? And how comfortable are you to disclose these results? If you don't know the answer, that's okay, because I'm here today to talk about my research results and returning secondary findings. So just a little bit of the background, we're seeing genomic sequencing becoming more common in research in clinic, and even the public is becoming more aware of genomics, largely thanks to COVID. In research, genomic sequencing is being utilised by genetic and non-genetic professionals, and this is increasing the chance of secondary findings being identified. But how common are secondary findings? For an individual, it's unlikely that they'll receive a secondary finding, as the current incidence is about 1 to 5%. But on a population level, that 1 to 5% could mean a fair few people have secondary findings. And this leads to a bigger question. Well, what do researchers do if they come across these secondary findings? While we have national guidelines that state genomic research results can be returned to participants and that they should have access to genetic counselling, these guidelines don't actually specifically state or provide instructions in how to do this. And researchers have expressed preference in wanting to return genomic information, but many of them don't have resources or capacity to contact participants. And we know from the literature as well that participants can handle genomic information, such as secondary findings, quite well, often with minimal distress. Next slide, please, Will. So for us, this highlighted a gap in identifying and returning secondary findings, which led to us establishing a service here at Garvan, run by genetic counsellors to support researchers in identifying and returning secondary findings. Our service is called My Research Results. So how did we do this? As we know, all good research starts with reviewing the literature, and this informed our initial framework in returning secondary findings as a service. To assess, though, if this service was relevant and met the needs and current practices, we spoke to stakeholders as well as consulted clinical services. From this information, we have two key groups that have helped guide and develop our service. The first group is our steering committee, which provides advice and direction from an operations perspective. The second group is our Genomics Advisory Committee, which assists us with clinical questions and reviewing variants, which is a bit like an MDT meeting. But we took this a step further and we worked with our lab bioinformaticians and variant curators to build an in-house pipeline to perform that secondary analysis. And here we have a simplified version of this pipeline. This has led to My Research Results to be one of the first services in Australia to provide genetic counselling and identify, report and return secondary findings. As well as in the corner, you can see there's a QR code which takes you to our website, so please feel free to check out, but we'll be on the next slide. Could I have the next slide, Will? And so thinking about what have we achieved so far. So thinking about the big picture, we have 5 cohorts across Australia that we're collaborating with. And with a total of 92 participants from those cohorts have been referred to us. From these, 67 results have been returned, and predominantly those results have related to cancer and cardiovascular conditions. And as you can see here, you can see the conditions that we've returned, as well as who we've contacted. But also engagement has been positive. So who we've spoken to, participants and next of kin, most of them have accepted genetic counselling and receiving those results and have been referred for confirmatory testing. And this is reflected in the quotes here that we have from some interviews we performed some time ago. And you can see here that they found this information quite valuable, particularly for their family and sharing that amongst them. Currently as well, we're also piloting our in-house pipeline with one of our collaborating cohorts. And early data is suggesting our pipeline is achievable and can be scalable for larger cohorts. So far, our incidence of identifying secondary findings in this cohort is around 2.5%, which reflects the current literature and estimated incidence of 1 to 5%. So overall, we can see My Research Results is an effective secondary findings pipeline and genetic counselling service. And our team is proud to be one of the first national programs in Australia to offer these services to researchers. But we also have future plans to grow further by developing future collaborations, upscaling, as well as commercialising My Research Results. So I'll finish with a question. Could you be our next collaborator? Thank you.
Thanks, Lucas. Great way to end the presentation. Love the question. Are there any questions from the audience for Lucas? Give people a few seconds to frantically type. Okay, nothing yet. So I might ask a question if I may. So with the people that are, I guess, that are coming through the pipeline, what kind of consent process are they having as part of that initial testing? You know, obviously they're going through research initially. Are they having full on consent with a genetic counsellor about secondary findings? And yeah, maybe if you can just explain that in a bit more detail.
Yeah, of course. So with some of these, for many of these cohorts, the consent has been previously done through the cohort owners and the research team. But our service has also been helping with other research projects and performing that consenting process and the genetic counselling around that. So we've been very much doing this, perhaps the standard genetic counselling, consenting around genomics, informing them of the option or the opportunity of secondary findings, and so I'd like to receive that information. But we've also done the highlighting as well of the implications that could have on them and their families, but also insurance. But in terms of what we return and who we return to, the types of findings we return mostly, well, actually are pathogenic or likely pathogenic variants. And we only return them to those that have actually consented. So we always go back and check the consent forms beforehand to make sure that people actually want to receive this information. So we're not just dropping bombshells on people. And even then, the notification process, we try to be as gentle as possible, sending out correspondence first before we're contacting them by phone as well. So yeah, it's a bit of a pipeline chain of events.
Great. Any questions? Otherwise, I'm going to ask another one. So I'm really interested in this. So I guess, have you found that there's a difference in the way that the patients react given what consent pathway they've gone through? So say, for example, you know, someone that's been consented via the research project that they originally signed up to versus, you know, speaking with you or a genetic counsellor prior to going through this pathway.
Most of the cohorts we've been working with have actually been consented some time ago. So that's been an interesting challenge. Perhaps when we've been talking to these people, we've had to do a bit of a recap of explaining the project again, reminding them a bit more. I suppose it's part of the rapport building as well. But some of these people perhaps signed up to a cohort 20 years ago. They weren't expecting to hear anything, but recently those samples underwent whole genome sequencing. So it's a bit hard to say what perhaps back then the consent conversation might have been like. So that's where we've kind of come in halfway through and just tried to have that gentle approach in terms of how we notify people. But we do work closely with the cohort owners as well and try and get as much information from them and how they've approached it. And often we get the cohort owners or the research team to do that notification process as well. So for them, it's the same people that most likely consented them are also notifying them again before they refer to us here at Garvan. So yeah.
That must be very interesting to talk to people that have been consented 20 years ago, I imagine. Yeah.
Yeah, it's interesting conversations, but most people have handled it really well and have been really thankful for the results.
Yeah. All right. Well, if there are no further questions, Lucas, thank you. We'll leave it there. Thanks again for a wonderful presentation. So I'd now like to hand over to Marianne.
Thanks, Kirsten. And thanks for the opportunity to present today. I thought I might follow a little path like Gillian did in talking about how I got into research, and then to talk about one of the projects that we're working on at the moment. Can I have the next slide, please, Will? So for those of you that don't know me, my primary role and the majority of my career has been spent as a clinician. What informs my research is my clinical interactions with patients, and my research career has really only been able to occur as a result of collaborations. So when I was a lot younger, I set up a familial cancer clinic at Peter MacCallum. And in sitting with patients then, this was back in the 90s when BRCA1 and 2 had just been cloned. And I sat there, and the thought was that people should follow the predictive testing protocol for Huntington's disease, that, as you know, for BRCA1 and 2. And we'd get patients coming in and we'd think, oh, we'll do 3 sessions and we'll try it out. And it was just complete resistance from the patients about coming back for a second session before they had their blood taken. And basically what they were telling us was that we were getting in the way of them having a test that they'd made a decision to have a long time ago. So I actually went back to university and I did a higher degree in qualitative research and to explore women's decisions about predictive testing for BRCA1 and 2. And the results of that research showed that, yes, women had made their decisions a long, long time ago. It wasn't by coming to the clinic that they were making a decision. And that really we were just acting as a barrier to them getting onto something that they'd already decided to have. So that led to a practice change in the sense that people just came in for one session and then went about and got their results. And then I went on to do, I've done more research, but it's always been in collaboration with other people. I don't have a PhD, I have a master's in research. I have been successful in getting grants, but like Steph said before, my first grant was just a small philanthropic grant. And often the research that I do is informed by gut feelings when I'm in the room with people. Could I please have the next slide, Will? So I want to talk to you about a large project that I'm involved in at the moment, which is again as a result of collaboration. It's called the PRIMO project, and it's a randomised controlled trial. It's a clinical trial, and it's looking at personalised risk assessment in women who are having predictive testing for hereditary breast and ovarian cancer. And we are recruiting 2,000 women from around Australia, and they are randomised to either receive standard practice in regards to predictive testing, or we give them personalised risk information using both monogenic, polygenic and other risk information. And there's a whole team of us doing this. There's 4 of us who are chief investigators, and then there's a whole lot of other people as well who are helping us along the way. So that collaboration is unbelievably important. So, Will, can I just have the next slide? It's always helpful when you remember what's on your slides, isn't it? So basically, I divided this up into what I think are the 4 streams of any successful research project. The first is project management, and you can't do a really big trial like this without having an excellent project management team. And we have 2 people based at Peter Mac who help us with this work, and without them we'd be lost. The second team is Paul James, Melissa Southey and Georgia Trench, and they're doing the actual genetic testing and generating the personalised risk information. Tatiana Yanes, who most of you will know, she's a genetic counsellor in Queensland. Tatiana took the stream of workforce education. Many of you will have attended the workshops that Tatiana's run so that people could actually deliver this personalised information through the trial. And then I lead the patient experiences, which is the stuff that I often lead in large research trials. Could we have the next slide, please, Will? I just wanted to give you an example of some of the work that we're currently doing. Lucas, Amanda and I come from Garvin, and we've got quite a few grants, and they're as a result of collaboration. So Amanda's going to talk about a project that we've got going on at the moment, which is called DNA Screen. We've been successful last year in collaborating with researchers in Victoria, and we've got a large synergy grant. Now, I could never have got these on my own. These are just as a result of part of the work that I and my team bring to these research projects. We've got the Primo grant, and then we've also got a couple of other grants that we've actually put in for as well. And the next slide, please. So in thinking about my reflection in regards to research, as all good genetic counsellors do, undertaking research is fun and it's very rewarding. It gives you an opportunity to explore things in ways that you can't do in clinic. And it's hard. You know, grant writing, staying up till all hours of the morning writing grants and getting them submitted by their due date, it can actually make you lose the will to live. I can be completely honest with that. Submitting manuscripts, I love that, actually. It's my creative part, it's my creative time. And again, I just can't underestimate the benefit of collaboration. You know, I was talking to Steph yesterday about a grant that we're going to be working on, collaborating again. I'm not an implementation scientist. You know, we need expertise, and Steph's exactly the person to work with. My clinical practice informs my clinical research. And I think one of the other things I was thinking about is I think understanding research theory is critical to doing research. How do you do research? Why do you do it that way? You have to be able to articulate and justify your rationale for what you're doing and why you're doing it. And I think that might be it from me, Will. Thank you.
Thanks, Marianne. That was wonderful. Does anyone have questions for Marianne? I can't ask all the questions. I feel like that's selfish.
You're very welcome.
People must have questions. Anyone? There we go. So a question from Lucy: how do you find the difference moving from clinical to research? Do you miss clinical work? Good question.
It is a good question. I suppose I still get, well, I don't do much anymore. Amanda and Lucas do most of it, but do I miss it? I thought I would. I don't, actually. I just find I've moved into another area of work that I'm enjoying. It's still associated with patients in the sense that it, you know, we do co-design. We have patient representatives on our steering committees. Do I miss being in the room with people? A little, but not enough to go back to a clinical role. And I still, you know, through the My Research Results platform, that's still actually providing it's clinical work. It's like providing genetic counselling, but it's just to research participants. I recruit people to whole genome sequencing studies through COVID. We were recruiting people to COVID studies doing whole genome sequencing. So we still get to meet with people. So it's still nice to have those interactions. Yeah.
Thanks, Marianne. Any other questions? Nothing that I can see. Might leave it there. Thank you so much. And next up, we'll have Amanda.
Thanks, Kristen, and hi, everyone. Yeah, I'm Amanda. I'm a research genetic counsellor, also working with the My Research Results team at Garvan. And as Marianne said, I'm going to talk to you today about a DNA screen project that I'm working on, and kind of using it as an example to highlight ways that genetic counsellors can make really valuable contributions to research. If you can pop on the next slide, Will. So the DNA screen study is led by Paul Lacaze and Jane Tiller at Monash University, and it was funded by a Medical Research Futures Fund grant. The plan is to test 10,000 young Australians, regardless of their personal or family history, for hereditary breast ovarian cancer, Lynch syndrome, and familial hypercholesterolemia, using online recruitment and male DNA collection kits. All of the participants will receive results back. The negative results will go by text and email, and carriers will get their results from a research genetic counsellor, with referral on for confirmatory testing and management. So the primary aim of this work is to gather evidence for the acceptability, scalability and cost effectiveness of population-based genetic screening in Australia, which is a really big undertaking. So a multidisciplinary team of investigators is collaborating on this. So we're talking about collaboration again, including epidemiologists, public health experts, lab scientists, bioinformaticians, clinicians, consumer groups, health economists, and of course, genetic counsellors. And on to the next slide. There are a lot of ways that genetic counsellors have added value to this research, just using this one study as an example. And I'd like to do a shout out to Jane Tiller and Marianne, who've done a lot of work on this study alongside me. So in this particular study, we had genetic counsellors included on the grant application, providing input into the grant. I think this is really important because it does acknowledge that GCs have relevant experience. Their knowledge of clinical pathways, genetic communication and patient experience is really valuable. And I think successful grants with genetic counsellors included reflects that. And, given the emphasis now on having investigator teams that have relevant expertise. Genetic counsellors were involved in developing the study protocol, making sure all the communication in the study documents and that are online are clear. The consent for genetic testing is adequate. Also designing the pathways for return of results and the referral pathways for people to get into the clinic. Genetic counsellors are obviously critical at the point of returning results to participants, with all the positive results returned by the genetic counsellor team at My Research Results. So we will provide people with their result information, provide them with support, advocacy, help with family communication, and help with getting into the clinics, as well as following them up after a period of time to make sure we can maximise the positive outcomes from the study. And again, when it came to evaluating the program, genetic counsellors had a lot of input again. First of all, highlighting the relevance and importance of psychosocial follow-up as part of the evaluation, as well as developing clinically relevant research questions and procedures to do that evaluation. We used our knowledge of existing research, particularly the limitations and gaps, to work on a study that builds on existing research and leverages the opportunities that we saw in DNA Screen. And genetic counsellors are often familiar with validated measures for use in the genetic setting, and a lot of these particular measures have actually been developed by or with input from genetic counsellors and are used commonly in genetic counsellor-led research. So I had the opportunity to lead the development of the psychosocial protocol, part of the evaluation. And onto the next slide, I'll just talk through what we've planned out. It's going to be a mixed methods longitudinal study, and it's just launched now. So our questionnaires are live as part of DNA Screen. We're administering questionnaires at 3 time points. When people register to DNA Screen, they'll all complete some baseline data. That's one of the opportunities that DNA Screen offered, because it's been a real challenge in a lot of other studies, returning genetic results, getting proper baseline data before anyone receives any results. So we managed to get that data in this study. And then we're going to do 2 more data collection points to see what happens over time with this group of people. So after receiving results, all of the variant carriers and a sample of the non-carriers will do a questionnaire, and a group will undergo a qualitative interview. And then again at 12 months, there'll be a questionnaire and interview with the same group of people. We lean heavily on existing research and kind of health frameworks to identify which measures we'd use. And we're going to look at things like risk perception, distress, adaptation to genetic information, health behaviours and other behaviours, and communication about results. And the results, we hope, will help to contribute to all of the data that's being collected around this study about whether population-based genetic screening can be implemented without causing distress, and with the hoped positive outcomes long-term in terms of sharing information with family members, positive health behaviours, and adaptation to genetic results. The in-depth semi-structured interviews that we're going to do will explore participants' experiences in more depth, looking at how they think about their risk and what they plan to do with the results. And that's going to help us to hopefully interpret some of the quantitative data. And if you could pop onto the next slide. I did mention earlier that this was a collaboration and a team effort. And you can see there's a big long list of people here who've been involved, but I thought it was a great example of how genetic counsellors can contribute really meaningfully to a large collaborative study and hopefully improve participant outcomes as well as generate evidence that could lead to changes in practice.
Thanks so much, Amanda. Just in the interest of time, I just realised that we're running short of time. We may leave questions for Amanda. I'm sorry, but if you've got any specific questions, I'm sure she would be very keen to hear from you. Thank you. All right, and I'll hand over to Elle.
Hi, everyone. I will keep this short. Really happy to share my slides. Thank you. No MCRI branding for this one. The brief of this was to talk to this group about why I have defected and become a project officer. So please bear with me. But let me start by saying, do you enjoy ordering people around instead of taking orders? Want to fall asleep at night knowing you have no unfinished clinic letters? Want the satisfaction of coordinating a team to enhance awareness and access to genomic testing? Want the ability to utilize your clinical skills and network connections to achieve meaningful career goals? And if you're a level 2 clinical GC in New South Wales, would you want higher pay? If you've said yes to one or more of these questions, defecting from the oppression of clinical work and becoming a project officer might be right for you. Thanks, Earl. Next slide. I can't tell if anyone's laughing, but I'll just imagine that you all are. But I digress. Who am I and what am I doing here? My name is Elle Martin. And up until 12 months ago, I was a board certified clinical genetic counsellor working in New South Wales. And it's not that I didn't enjoy working clinically. In fact, I loved working with clients at my old job. However, after working for nearly 6 years in more traditional genetic counselling roles and after working remotely throughout the pandemic, I was looking for a way to expand my skill set and gain further career diversity and flexibility as well. So that led me, following sage career advice from my work wife, Kirsten Boggs, who also happens to be here today, to apply to work as a project officer across 2 national studies. And these are the UDN Oz and MITO MDT projects. These are both based at the MCRI. I won't go into too much detail about the projects, except to say that they're both national MRFF funded projects, and they're aiming to streamline and standardise access to genomic testing, reanalysis and functional studies for patients with undiagnosed rare conditions. And I work with wonderful teams across both projects, including a stellar team of genetic counsellors for UDN Oz, a project assistant who's fantastic, Maddie Harris, geneticists, scientists and other health professionals to achieve project goals, with my role essentially being to ensure streamlined and timely rollout of these 2 national studies. So for example, I have input into ethics and governance applications, budgeting, reporting, subcommittee organisation, auditing and overall management. They are more interesting than they sound. So why did I get the job? Well, after my interview, I was asking myself the same question. Tiff Bortwood was on that interview panel, and she can attest to how badly it went. But however, after I started working, it didn't take me long to realise just how invaluable my genetic counselling experience is in managing both of these national projects. And I thought I'd quickly mention some key skill sets gained from my clinical role as a GC and how they directly apply to my work as a project officer. So firstly, a knowledge of patient pathways and testing requirements has been invaluable. It's meant that I've been able to meaningfully contribute to the development and review of project documents, protocols, consent forms, patient information, etc. I've been able to leverage existing resources. I have a good understanding of what is required for adequate participant consent and documentation. And these have all worked together to enable, I guess, an easier governance and ethics application process. It's also been really helpful for database development. So knowing what we need to record and what we don't need to try and streamline data entry for the poor people working on these projects, and also project troubleshooting overall, questions about sample requirements, questions about testing outcomes from stakeholders. It's been really, really useful. Knowledge of key contacts, so lab staff, clinicians, other I shouldn't say clinicians, clinical genetic services and other subspecialists, has really streamlined communication, allows for efficient hiring of project staff and optimises team management. And I feel like I've started off on the front foot with this. I can't imagine what it would be like trying to work in this role without having worked clinically as a genetic counsellor before. Interpersonal, interpersonal and counselling skills, essential for stakeholder engagement. You all know this. Ops team management, not that they need managing. Liaising with grants and legal, they do need managing, so this is very useful. And also working with our community advisory groups for the projects. And finally, organisational and prioritisation skills. We've all triaged wait lists. We all have an understanding of what's clinically urgent and what's not. And that has been really helpful for me, translating over into determining what is actually a real deadline and what is perhaps misguided urgency. So that's really helpful for milestones, deadlines, report writing and review, and also just general subcommittee organisation and agenda planning. So why do I like this job? Well, I work with a fantastic team, so that's number one for me. But not only does it allow me to use the key skills I've developed throughout my genetic counselling work, it's enabled me to increase advocacy for access to genomic testing, increase advocacy for the role of genetic counsellors in research. Without the genetic counsellors on these teams, these projects would not run. And I make that clear to all stakeholders and hopefully to the GCs working on these projects as well. And essentially, I'm still in the same field as I used to be, but I'm playing an integral role in the delivery of genomics at scale. And personally, I find that very satisfying. So if you want to know more, please feel free to contact me. Well, if you click again, there you go. My email is there. I've also put a link to a really helpful project management course that I did at the Centre for Continuing Education at the University of Sydney. If anyone is interested, if I've convinced you, please let me know. I'm sure there are many MRFF funded projects that will be looking for project officers very soon. Thank you.
Thanks, Elle. I think you've convinced a lot of people from what I can see in the chat. So again, in the interest of time, we may just leave it there for questions, but if anyone's got any questions, you now have Elle's email address, so you can contact her. I'm sure she'd be happy to hear from you.
Thanks, everyone. Thanks, Kirsten.
Thank you. So Will, if you just want to pop up my last slide, please. Just to say thank you. So I really appreciate all of you for attending. Thank you so much for being part of our very first GCR Connect Showcase. We really are hoping to drive the message forward that genetic counsellors play a key role in research, not just within genetic counselling research, but within other genomic and genetic research, I guess nationally and also hopefully internationally. Thank you again to all of our panelists for their wonderful presentations today. And should you have any questions for us, our contact details are there. So give us a follow on Twitter if you haven't already at GCR Connect. And that is our email address should you have any questions, suggestions, feedback, anything at all. Thank you again, and we look forward to seeing you next time.